All right, so welcome everyone. For those that don't know me, I don't know if there is anyone who doesn't know me. I'm Dean. I'm one of the EM registrars, and I was rotating through Rahima between February and end of April. Um, so yeah, this is a talk that I did back then that I'm just representing. On brief resolved unexplained events. And I don't think anyone will blame you if you've never heard of such a thing. It's not a commonly thought of and sort of come across diagnosis, but it is something that you guys might come across in future. So let's get into it. So previously, there was an entity called an apparent life-threatening event, or ALTE. And anyone who's a parent will realize that there's a lot of frightening events that happen with children. But this one is specifically an event that the observer sees apnea, color change, a change in muscle tone, or choking and gagging. It's been revised. The task force on brief resolved unexplained events have made that an obsolete term, and it's now been replaced by BRUE. So I am not going to be talking anymore about ALTE, but if you guys come across it in your practice, that is what it is. It is now synonymous with BRUE, and BRUE is the more sort of correct and up-to-date term. All right, so a ALTE versus a BRUE. Well, a brief resolved unexplained event is a bit better defined. It is an episode in an infant, so less than 12 months, characterized by less than a minute's duration, return to baseline, and the important thing, it cannot be explained by another identifiable medical condition. And it has to have one or more of the following: central cyanosis or pallor, absent, decreased, or irregular breathing, a marked change in tone, and altered level of consciousness. And we'll go through those briefly. All right, so it's important to stick to the criteria. If you deviate from the criteria, it's no longer a BRUE, and you need to be very strict with yourself when considering this as a diagnosis, because we consider this diagnosis to allow a child to go home. And if they don't fulfill all of the criteria, there's a risk that you're sending a child home with a potentially life-threatening condition, not a BRUE. So I'm just really going to go through what is excluded in these event characterizations. If you guys want to come back to it and go through this table in your own time, that's also, I think it's a good idea. So with the cyanosis or pallor, perioral cyanosis, rubor, and acrocyanosis are excluded. Absent, decreased, or irregular breathing, the periodic breathing of the newborn or a breath-holding spell is not part of the criteria. Changes in tone, hypertonia associated with crying, choking, gagging, or gastroesophageal reflux or feeding problems associated with breath-holding spells. And then if there's tonic-clonic seizure activity, infantile spasms, or eye deviation or nystagmus. So anything that would suggest a seizure, this is not part of it. And I think that's really important, that the changes in tone are purely tone changes. There's no clonic movement, and there shouldn't be any eye deviation. And then altered responsiveness, it excludes loss of consciousness associated with a breath-holding spell. And you guys will see that breath-holding spells mentioned a lot, because these are two diagnoses that are actually quite easily confused, but they are not the same thing. Okay, so this is the ED protocol at Rahima Musa for the brief resolved unexplained events, and it is based on the one that was published in the American Academy of Pediatrics for BRUEs. So it is essentially the same, it's just a little bit easier to read, and I'm going to break it up in the next couple slides. Right. So this is the first part on how to make a BRUE diagnosis. All right. And if you're going to make this diagnosis, you need to have done a very thorough investigation.
Put on the group.
Okay, so they will arrive for a
Hi guys,
assessment.
please can you all mute yourselves? Please remember to mute. It's just disturbing for Dean while he's trying to present. Thank you.
Good, yeah. All right. So inevitably, this patient will present with a caregiver and the patient will arrive to you. This infant will be completely well appearing. If they have anything that is abnormal, it is not a BRUE. And that is the first part of this. You are called to assess a child and this child is well. Then based on history, you need to get those key points that we've gone through previously, the cyanosis, breathing abnormalities, marked change in tone and altered responsiveness, and you need to have that be brief and fully resolved. If any of the event criteria is absent, this is not a BRUE. If it's present, you have to do an appropriate history and physical examination, specifically searching for an explanation of the event. And I just want to highlight that this is a diagnosis that you guys must actively try not diagnose. You need to be actively looking for another reason for this child to present. This is really the diagnosis of exclusion of all diagnoses of exclusions. If you cannot find another explanation, then you've made your diagnosis of a BRUE. Right, so that's step one. And taking a history, it has to be so thorough. Be very, very vigilant for child abuse and neglect. You need to know exactly what happened at the event, during and before, as well as after. How did it stop? Did this event stop with infantile spasms, or was it just a sudden return to baseline? You would need a thorough past medical history, which is easy in a 12-month-old or an infant. They haven't had that much past medical time. But look, if you have a child that has background neuromuscular diseases or is known with developmental. Alrighty, where was I? Okay, yes. So a child that has a background history of a congenital disease, particularly neuromuscular disorders, this is not a diagnosis that you're going to be able to make. So you want that thorough medical history, and you guys can see what I've added there: vaccinations, travel, medications, a family history, BRUE in a sibling, consanguinity, arrhythmias. Be very cautious around a family history of arrhythmias, particularly if there has been a sudden death in a patient or a family member that was otherwise well and quite young, that might suggest a channelopathy or a conduction abnormality that was never diagnosed. But yeah, that's a whole lecture on its own. And then social and environmental history. All right, and then examining this infant, full examination and anthropometry, which I hope that you guys are doing on every infant anyway, that comes in. They need to be, all clothing needs to be removed, including a nappy, and you need to be looking at any evidence of trauma, any dysmorphic or syndromic features, a full neurological examination, and check for any viral infections, especially upper respiratory tract infections, which we are very used to diagnosing. And it's also really important, and this should be part of our assessment of any child, is upon walking towards a child while they're with their caregiver, look at their interaction with their caregiver and with their environment. It's normal for a child to be a little bit afraid when they come to the hospital. It's a new environment, but they should be seeking comfort in their caregiver, not away from their caregiver. So those should be red flags, not just for this diagnosis, but for just in general. And then any deviation from normal development is a red flag. Okay, so after you've done a thorough history and examination, you've diagnosed a BRUE. Now what? Now you need to decide if your patient is low risk or high risk. All right, so if there's no concerns and is not in a high risk age group, which is any child under 60 days or was born prematurely, and the corrected gestational age is less than 45 weeks. I know I'm saying this backwards because what is written here is the low risk criteria, and I've just mentioned high risk. So particularly the younger group or the premature group that hasn't reached a corrected gestational age greater than 45 weeks. So if they don't have any of these high risk age group criteria or any other high risk criteria, they would be considered a low risk BRUE. CPR might have been initiated by an untrained bystander, and that's a very important thing. A lot of parents or nannies or caretakers might have started CPR. But if it was initiated by a medical professional, someone who's got training, you automatically have to classify this child as high risk. You weren't there, you weren't able to make that assessment, and this person with training decided that this child required CPR, so it needs to be taken seriously. Any repeated events needs to ring warning bells, and yeah, it has to obviously last less than a minute. If it lasted more than a minute, this is not a BRUE. All right, now we're going to quickly discuss low and high risk patients separately because they are managed differently. Okay, so a low risk BRUE, and the subcommittee had identified low risk criteria, and there's in the references, there's the entire referendum that they sent out, giving out their references and recommendations regarding low risk BRUEs, and if anyone wants to see what the actual evidence says. The important thing is these children don't need an extensive workup. There's a few things that they recommend. They do recommend offering CPR training to caregivers and considering doing pertussis testing as well as a 12-lead ECG as screening to see if there is a risk of potential repeated events. This is recommended. You don't necessarily have to do it, but I do think that if there's anything that makes you think that this might have been not a BRUE, you should go ahead and get that pertussis testing and that 12-lead ECG. Particularly a 12-lead ECG, it's a low-cost test that can be done point of care. And I'm part of the group that believes that everyone coming through the door of an ED should get an ECG because you never know what you're going to pick up, and it can be potentially life-saving in all patients. Then we've got high-risk BRUEs, and there's unfortunately no official guidelines on how to investigate them. There's a much higher risk of underlying pathology, and there's a massive differential diagnosis. So the reason why they're not low risk should guide your investigation. And I'm just going to quickly take you back a few slides to the criteria, just to highlight. If they are very young in the sort of first 2 months of being of life, you should go along the lines of a neonatal workup, sepsis, thinking of infections, potentially something congenital. If there was CPR that was done by a trained medical provider, think about cardiac and respiratory issues. If there's repeated events, yeah, look, there's a very long differential for that. But think about something congenital, respiratory, neurological, cardiac. Can I just ask whoever is not muted to just mute, please? All right.
Dr. Henning. Dr. Henning, please won't you mute yourself?
My apologies.
Thank you. Sorry, it's so disturbing for the presenter.
I didn't realize I was sorry.
No stress. Cool. All right. And here's my small little spider diagram of the differential diagnosis. And yeah, we're absolutely not going through all of it. I've tried to separate it into the different systems so that you have a little bit of a direction in which to go. But there's a lot here to look at. I just want to highlight a few of these. So congenital heart diseases and channelopathies, if there's any family history of anything, be very, very cautious about this. Think cardiac, particularly in the younger group. If they were born prematurely, make sure that you do a thorough cardiac exam and you are considering these, get that ECG. And the infection and respiratory, you guys will see infections, upper and lower respiratory tract infections. We see them a lot, and they can have really varied presentations, as you guys well know. So they will always be on the differential diagnosis, as will a breath holding spell. The non-accidental and toxin exposure, these are difficult to elucidate, and this is a completely different talk on its own, looking at non-accidental injuries. But you have to have a high index of suspicion, because if you miss it the first time, there's a good possibility that the child won't represent. Unfortunately, that's just the nature of the event. Neurological, there are a whole lot of options that can cause a BRUE type picture with sudden changes in tone and loss of consciousness. So this is absolutely something that needs to be considered and ruled out. And then, I mean, we can literally just go around this entire spider diagram and talk about each one. I think the main point of this is there's a massive differential diagnosis. And if you haven't done a complete examination and history, there's a good chance that you will miss any of the subtle signs that are telling you that there is something underlying. Some of these are benign, but some of them are absolutely life-threatening and need to be dealt with immediately. So yeah, come back to this when you guys have a chance, have a look at the long list of things that can present with that presentation. And I think the important thing is everything on this list, the infant can present well. And that is quite a scary prospect, that these children can come in with normal vital signs and nothing that you can pick up sort of at first glance. And you really need to be thorough when dealing with infants to not miss anything. So what is my take-home message? It's a diagnosis of exclusion. Absolutely. You need to adhere to the criteria to safely discharge. And caregiver education is the most important thing if you are going to be discharging this patient. Thorough history and examination can't be overstated. I've harped on about it over and over. Be careful about those insidious pathologies. All right, so I just want to quickly talk about two of the differentials very, very quickly. So breath holding spells. I don't know if any of you guys have ever seen them. There's a link to the YouTube video, and I'm going to see if I can play it for you guys afterwards. It's basically an episode where a child cries excessively, then holds their breath. It can happen after essentially anything. Anything painful, frightening, irritating, or when they're getting disciplined or becoming angry. It's not intentional. This is not a tantrum. It can look like a tantrum, but the child does not sort of intentionally hold their breath until losing consciousness. All right. It may include syncope, cyanosis, or pallor, and there may be seizure-like activity, but there's no post-ictal period. And that's a very important thing. When the child wakes up, they have returned to baseline. All right. It's actually fairly common. About 5% of children between 6 months and 6 years. It's a benign event, and it's absolutely reasonable to do an ECG and a hemoglobin and a stat hemoglobin if you've got access, or a blood gas if you don't. I'll come back to this video. And then the other thing, what about SIDS, doc? And I don't know if any of you guys have been asked this question, but sudden infant death syndrome is very prominent in the minds of a lot of new parents. And this is a terrifying prospect to people, that their infant could just suddenly die and they have no idea what happened. And essentially, that's what the diagnosis is. It's a sudden unexpected death between 2 weeks and a year, in which examination of the death scene, post-mortem, and clinical history failed to show a cause. It's the most common cause of death in that age group, peaking between 2 months and 4 months, and the cause is unknown. But it is likely to be a syndrome, but they do think that it's due to dysfunction of the neurocardiorespiratory control mechanisms, and that in cases where there's respiratory compromise, there's a failure to arouse the infant so that they would actually wake up and improve their breathing or cry. And similarly, there's an inability to detect hypercapnia. And then cardiac channelopathies, which is an entity in its own that is terrifying to anyone that sort of has seen a sudden cardiac event, whether it's in a child or in an adult. So there are a few risk factors that can be modified, and this is the important part. The first part, there's nothing you can do about, but there are certain risk factors that they've found that increase the risk of SIDS, and that is prone sleeping. The old unsafe cribs is a bit of a difficult thing to elucidate, but really what it's going for is anything that could obstruct the airway of the infant. So bed sharing is the same thing. The infant's airway could be obstructed against whether it's a bumper, whether it's against the caregiver, whether it's against the mattress or soft bedding. Smoking in the home increases the risk of this, and then overheated environments. And it's quite difficult because most of the temperature recommendations come from Europe, which means that you would have to have an aircon on in the room during summer. But I think it's safe to say that you would like to keep the temperature in an infant's room under 30 degrees, just for safety. I mean, you really don't need to be cooking your baby. And then advice to the caregiver: remove any hazards from the carts. Don't bed share. Bumpers look cute. They're very nice in Mr. Price Home, but they're actually a hazard to children. So don't have those while you have an infant. Stop smoking and fire-related heating in sleeping areas. This can be very difficult in our population, that a lot of them live in single room homes and they only have fire-based heating. But with that comes the last point, that infants should not sleep on the ground, but rather be 0.5 meter to 1 meter above floor level, but then they're going to need safety barriers. So this is an entity that's actually quite difficult for us to provide reasonable, actionable advice to the caregivers if they come from a very disadvantaged background and they're very poor. But I think you need to give the advice to the caregiver and see how we can try help them to actually achieve this, if this is something that they're really worried about, particularly if there's been a family history of it. If there's been a family history of SIDS, do that ECG, look for a cardiac cause. Right. Then let me see if I can show you guys this video of the breath holding spell. Right. Are you guys seeing my Safari loading? Alrighty, so unfortunately they don't show this child completely from normal, but this is a child that's been crying, obviously something distressing, and now we reach that breath holding, and you can see it this child just goes completely unresponsive, and then you have the seizure-like activity. And I think everyone can agree that this would be terrifying to a caregiver. I know if I saw my son do this, I would be horrified, even with the knowledge that I have. And it's very brief, and then the child will wake up and essentially return to baseline. To be honest, I would be quite skeptical about calling this a breath holding spell from the beginning. Alrighty.
Thank you so much, Dean. Is anybody got any questions or any comments for Dean? I'm going to say thank you so much for presenting for us, Dean. I really appreciate.
My pleasure.
I'm going to log off, and I'm going to ask everybody else to do the same. Thank you again for doing your talk for us, Dean.
Cool. Pleasure. Thanks, guys. Thanks for tuning in.